Welcome to the body imaging cases. This is a case of an incidentally seen pancreatic lesion on ultrasonography in a young male. The lesion is rather homogeneous. It respects the splenic vein, although it is very close to it. And the pancreatic tail does not show any alteration of signal intensity or any dilatation of the pancreatic duct. The lesion has the same signal intensity as that of the spleen on all steps of the diffusion weighted images. And consequently on the ADC map. The same signal intensity as the spleen on T1 weighted images. And here we notice that the pancreatic parenchyma, the normal pancreatic parenchyma, is bright on this fat saturated T1 weighted images. This is a very important pulse sequence to look at the pancreas. It allows us also to generate three-dimensional images of the pancreas, which is the brightest part of its surroundings. And this is a fused image of the fat saturated T1 weighted image plus the diffusion weighted image. And this is the gadolinium enhanced MRI showing enhancement of the lesion, which proves that we are dealing with a solid pancreatic lesion. Let us discuss the differential diagnosis of this solid pancreatic lesion. We have four disease entities: adenocarcinoma, neuroendocrine tumor, solid pseudopapillary pancreatic tumor, and intrapancreatic accessory spleen. The red color means lesions that need to be treated surgically, and the green color means a lesion that is completely benign and needs to be left alone. Please keep this color distinction, which is management distinction, in mind, because we will base our differential diagnosis on management. From the images we have seen and from the clinical background, we have certain features with each of the four disease entities and features against each of them. The patient was asymptomatic, was young. We have seen no pancreatic duct dilatation, and the lesion respects the splenic vein. It is very well defined, and it shows homogeneous signal intensity, and more important than that, homogeneous diffusion restriction. All of these features are against the possibility of adenocarcinoma. On the other hand, the well definition of the lesion and the matching signal intensity and diffusion restriction are features suggestive of intrapancreatic accessory spleen. Therefore, we may reorder our arrangement of the 4 disease entities, making the intrapancreatic accessory spleen the highest probability or the most likely diagnosis, and hoping for the sake of the patient to leave the patient alone. But now it is the time for the second thoughts. As you see, the lesion is not at the tip of the tail of the pancreas, and the intrapancreatic accessory spleen is most of the time there. And the more you encounter it away from the tip of the tail, the more the probability decreases. The second feature against intrapancreatic spleen is the slightly higher signal intensity on T2 weighted images of the lesion compared to that of the spleen. And the enhancement is also against the possibility of intrapancreatic spleen, because on the arterial phase of the dynamic gadolinium enhanced study, we expect the intrapancreatic spleen to enhance exactly as the spleen itself. This means very strong arterial enhancement with or without the zebra line pattern of the normal splenic enhancement. The traditional approach to the differential diagnosis is to try to reach the single best diagnosis from a list. The management-based approach is different. In the traditional approach, the next step may be a biopsy to get the specific diagnosis, or a dot-tate PET-CT to increase, if positive, the probability of neuroendocrine tumor. But from the management-based perspective, all we need now is to completely eliminate the possibility of intrapancreatic accessory spleen, the only green possibility, the only lesion that can be left alone. After that, the decision is easy. It is to go inside and remove the lesion. Imagine we have chosen the dot-tate PET-CT option, and imagine it is positive. In this case, it may increase the chance of neuroendocrine tumor. It will entirely eliminate the lower two possibilities, the adenocarcinoma and the solid pseudopapillary pancreatic tumor. But the intrapancreatic accessory spleen will show uptake also, because the normal spleen will show uptake of the dot-tate. In this case, we will remain with the same management dilemma, to operate or not to operate, and no honest surgeon would go inside and remove an intrapancreatic accessory spleen. Therefore, we have chosen to take the option of the colloid SPECT. The colloid goes to the reticuloendothelial system. This means the spleen and the Kupffer cells of the liver. And the fact that the lesion is not showing uptake here finally eliminates the possibility of intrapancreatic splenic tissue. So this could be the straw that broke the back of the intrapancreatic spleen. And the mission is accomplished. Now the decision is taken. We can go inside and perform distal pancreatectomy preferably with sparing of the spleen, because even if this is an adenocarcinoma, which is the worst of the three, it will be enough to do this distal pancreatectomy, considering that the lesion is resectable and limited to the pancreatic tube. The patient has been operated upon, and the diagnosis proved to be solid pseudopapillary tumor of the pancreas. Knowing the diagnosis, we went back to the MRI and found a very helpful sign of solid pseudopapillary tumor. The lesion shows significantly low signal intensity on the in-phase image compared to the out-of-phase image, the exact opposite of what happens to the fatty liver. This is due to the accumulation of iron within the lesion due to hemorrhage. And it is better appreciated when we subtract the out-of-phase image from the in-phase image. Now it is clearly seen as a dark crescent within the lesion. So the learning points here are: differential diagnosis is a dynamic process, changing all the time to accommodate new observations and new data. It is a process that needs to be linked principally to patient management, not to reaching a definite final diagnosis. If a definite diagnosis can still be made, then it is a good plus. Though rare, solid pseudopapillary pancreatic neoplasm may affect males. More frequently, it is a disease of young females. Eccentric crescent-shaped hemorrhage within the pancreatic lesion is a helpful sign for the diagnosis of solid pseudopapillary pancreatic tumor. Our next case is a female with a right loin pain and history of right ureteric catheter some time ago.